I'm going to be talking to you in the next kind of 20 minutes or so about haemolytic disease of the newborn. So my name is Julia Arthur. I'm one of the neonatal consultants working in Cambridge, and I also work for the Panda transfer team. So this is where I work. It's the Rosie Hospital in Cambridge, and this is the Panda transfer team logo. And haemolytic disease of the newborn is relevant in both of these situations. So we often look after babies with haemolytic disease of the newborn in our tertiary NICU in Cambridge. And sometimes we'll need to transfer babies from smaller local neonatal units to tertiary centres like Cambridge for treatment of haemolytic disease of the newborn. Next slide, please. So I'm going to talk to you about the history of haemolytic disease of the newborn, pathophysiology, diagnosis, and then management. Next slide, please. So haemolytic disease of the newborn used to be a major cause of fetal death and fetal loss. And it was actually first described in 1609 by a French midwife who essentially described twins that she delivered, one being very swollen and died soon after birth, and the other developing jaundice and dying several days later. But they didn't really understand the pathophysiology at this point, and it was only in the 1950s, looking into this disease further, that they discovered that the disease process was that the baby's red blood cells were being attacked by maternal antibodies. And then in the 1960s, there was trials in the US and the UK which looked at giving therapeutic antibodies to women at risk of haemolytic disease of the newborn, and found that actually these antibodies largely prevented the development of the disease. And then in the 1970s, as we do now, routine antenatal care included screening of all expectant mums looking for abnormal antibodies or Rhesus antibodies, and giving them preventative treatment. And that's where the anti-D injection started. And actually, with the use of anti-D, there's been a dramatic decrease in haemolytic disease of the newborn, especially the severe form of the disease that causes stillbirth and neonatal death. And actually now in our neonatal units, we do rarely see severe cases of haemolytic disease of the newborn. Next slide, please. So this here looks a bit at the pathophysiology. So what's going on? So our maternal red cell antibodies are IgG antibodies, and these antibodies can cross the placenta. And it's important that these can cross the placenta because the baby's immune system is quite poor, and they need maternal antibodies in order to help protect them so they can grow and develop. So we want the maternal antibodies to cross the placenta to protect the baby. But in some cases, the antibodies that cross the placenta aren't protective, and they actually cause problems to the baby. And that's what happens in haemolytic disease of the newborn. So these antibodies are recognizing the baby's red blood cells as foreign and start to break them down. So the babies become anemic. They get an increase in bilirubin levels, which is the byproduct, so the breakdown product of red blood cells. Babies who become anemic can go into heart failure, and this can cause them to become hydropic. So this is that swollen baby that the midwife described. And they can become very jaundice, which is also a dangerous thing for babies because it can cause permanent brain damage. Next slide, please. So if we think about Rhesus incompatibility, so like I said to you, Rhesus incompatibility is actually less commonly seen now because of the good screening we have for mummies, or we identify Rhesus negative mummies and we give them the anti-D injection. But essentially what happens is you've got this mummy who's Rhesus negative, so she's got a red blood cell with no little blobs, no little Y-shaped antigens on the surface. And then you've got a Rhesus positive baby who's got the little Y-shaped antigens on the surface. At some point during the pregnancy, there's a sensitization event, which means that some of the fetal blood enters the maternal blood. So this might be a bit of bleeding in pregnancy, it might be during a miscarriage, or actually during delivery itself. When baby's blood crosses into mum's bloodstream, the antigens on the red blood cell surface are recognised as foreign, and the mum makes these anti-D antibodies and breaks down the red blood cells. So we don't normally see any problems in mum's first pregnancy with haemolytic disease of the newborn caused by Rhesus incompatibility, because essentially that little bit of blood that's gone across, the red cells have been broken down, and then that's finished. But the mum will now have circulating antibodies against this Rhesus positive baby. blood. So if they have subsequent pregnancies of babies who are Rhesus positive, these IgG antibodies can cross the placenta and then start to break down the baby's red blood cells. So we often see that in kind of the second, third, fourth pregnancies, hemolytic disease of the newborn, if not treated, can be more and more severe. But like we said with the anti-D injection, this has mostly prevented hemolytic disease of the newborn, because if you can pick up mummies who are Rhesus negative and give them anti-D antibodies within 72 hours of a sensitization event, essentially these antibodies will attach to the baby's red blood cells antigens and prevent the mummy producing any further antibodies. So therefore you don't have the antibodies to cross over to the fetal circulation in subsequent pregnancies. So it's been an amazing kind of advancement in terms of prevention of hemolytic disease of the newborn. Next slide, please. So we've talked about Rhesus incompatibility, and I said to you it's actually quite rare that we see Rhesus incompatibility now causing hemolytic disease of the newborn. We still see hemolytic disease of the newborn in a milder form caused by ABO incompatibility. And this has a similar pathophysiology. This happens when you have a mum who is group O and you have a baby who is either AB, A, or group B. So you can see from the picture here, the group O red blood cell hasn't got any of the little kind of blobs on it. So it's got no antigens on its surface, whereas the other blood groups have got these little antigens on. So you can see that the group AB has got A and B antigens on the surface. Group A has got B antigens on the surface, and group A has got A antigens on the surface, and group B has got B antigens on the surface. So what happens is mummies who've got group O blood have got no antigens on the surface, but they do have antibodies within the serum. So they've got anti-B and anti-A antibodies within the serum. And because these are IgG antibodies, they can cross over into the fetal circulation. And these anti-B and anti-A antibodies can start to break down the red blood cells depending on that baby's blood type. It's seen in a milder form, so often these babies become a bit jaundiced, they become a bit anemic, but don't normally have the severe form of hemolytic disease of the newborn. And that's because the expression of these antigens on the red blood cells are less in the fetal circulation as compared to kind of adult circulation. And also these antigens are also expressed on other tissues within the body. Therefore, the antibodies have more antigens to bind to, so they're less likely to just bind to the red blood cells. So we see it in milder forms. Next slide, please. So this is just all the blood types. So this is what I was explaining to you about the different antigens and antibodies on the blood types. And it's important to know this when we're thinking about our ABO incompatibility, because if we have got a mummy with an O blood type, then we're more likely to see ABO incompatibility than if we have, a mummy with an A or a B blood type. So you can see on the O blood type, like I described, there was no antigens on the surface, but there are anti-A and anti-B antibodies within the plasma. And we describe this blood type as a universal donor. So a patient or a baby or a mum who's having a massive blood loss that needs urgent blood, we'd request O negative blood. And O is because we're giving packed cells, so we're only giving the red blood cells, so none of the plasma. So we'll just be giving the red blood cells with no antigens on the surface, and we won't be giving any of the plasma with the antibodies in it. And obviously negative blood because we don't want to have any kind of Rhesus incompatibility. The AB blood type, you can see, has got A and B antigens on the surface, but no antibodies within the plasma. And we describe this blood type as the universal recipient. So this person with AB can be given any type of blood because they've got no antibodies within the plasma that can then cause the red blood cells of the donor to be broken down. And then you can see with the A and the B blood type, the A blood type has got anti-A antigens and anti-B antibodies within the serum, and the same with B antigens on the surface and anti-A within the serum. Next slide, please. So we've described kind of what happens with hemolytic disease of newborn and the most common causes, which are the Rhesus incompatibility, which causes the severe form, and the ABO incompatibility, which causes a milder form. But how do we pick up hemolytic disease of the newborn so we can manage it effectively? So we've talked about antenatally, the screening, and this is the first time point that we could pick up a baby at risk of haemolytic disease as a newborn. So if a mummy has positive antibody screen, then we're going to keep a closer eye on this baby. If she's Rhesus negative, we'll give her anti-D. These babies will be flagged up to the neonatal team in order to kind of monitor them more closely after delivery. Sometimes if they're not picked up on antibody screen, or even if they are picked up on antibody screen and they're being monitored during pregnancy, on the ultrasound scan, we can also pick up evidence of haemolytic disease of the newborn if it's more severe. So if babies are becoming anemic, this can be picked up looking at Dopplers. And also we can see babies who are hydropic in utero. So hydrops essentially means that the baby's got 2 or more fluid-filled space within the body. So it may be fluid in the lungs, pleural effusion, fluid in the abdomen, ascites, fluid within the skin, kind of skin edema, or a pericardial effusion, and that can be picked up on ultrasound scan. Postnatally is the second time point where we could pick up haemolytic disease of the newborn. So if we've got a mummy with a positive antibody screen, these are the babies we would keep a closer eye on and do blood tests early. And we may see a rapidly increasing bilirubin level or a very high bilirubin level at birth. And we might see evidence of hemolysis, red cell breakdown. So we might see a baby who has initially a normal hemoglobin, but then within the first 24 hours, we rapidly see the hemoglobin decreasing. And finally, laboratory tests can help us diagnose haemolytic disease of the newborn in the context of the clinical picture. So we do direct antiglobulin test or direct Coombs test to look for evidence of hemolysis. And we can also do a blood film to look at evidence of hemolysis on the blood film, and we can look at the hemoglobin and the bilirubin levels, which all, with the clinical picture, can help us understand what is going on with that baby. Next slide, please. So when we're talking about antibody screening, so we look at the Rhesus and we look at the blood group, but also there's other antibodies that can be picked up within the screening process. So things like anti-Kell, anti-Duffy antibodies, which are all quite rare antibodies, but actually if we pick them up, we know these babies potentially are at an increased risk of haemolytic disease of the newborn. So these are the babies we will monitor more closely after delivery, monitoring their bloods and their jaundice level. Next slide, please. So this is what I was talking about when we do antenatal scans. So this is a very severe form of haemolytic disease of the newborn where the baby's very hydropic. So you can see in the ultrasound scan imaging, you can see the pleural effusion, which is labelled, which is essentially the fluid-filled space around the lungs. Ascites, which is fluid within the abdomen. You can also see a bit of kind of swollen skin edema. And sometimes these babies will have a pericardial effusion. And actually at delivery, these babies can be very challenging. If you imagine if you've got fluid around the lungs and you're not able to expand the lungs properly, and sometimes we will need to put a chest drain in to relieve the pressure. Sometimes because the abdomen's so big, full of ascites, again, you can't inflate the lungs properly, so you may have to do an abdominal drain to relieve the pressure. And if you look at the baby, the actual picture of the baby on the right, you can see he's very swollen, and actually just the logistics of delivering a baby with a very large swollen head can be problematic. So sometimes the delivery itself can be quite difficult. And when babies have severe hydrops like this, the morbidity and the mortality is very high. Next slide, please. So when we pick up a baby from screening who's at high risk of jaundice and haemolytic disease of the newborn, then we want to monitor them carefully postnatally. All babies get a little bit jaundice, and it's a normal part of being a baby being jaundice, because in mum's tummy there's a higher amount of red blood cells, and then when they deliver, some of the red blood cells start to break down. And like I mentioned earlier, bilirubin is a breakdown product of red blood cells. So jaundice is normal, it's physiological, but it becomes pathological if in the first 24 hours the jaundice levels are very high or the jaundice levels are rapidly increasing. And if this happens, we have to think this is a pathological jaundice, what's going on? In all babies, we think of sepsis first because that's the most common, most treatable cause of early jaundice. But we also need to think about hemolysis. Is there some kind of incompatibility going on? And again, like I mentioned before, we can look for hemolysis by looking at the hemoglobin trends, direct Coombs test, or evidence of hemolysis on blood films. Next slide, please. These are the the jaundice charts we use, and we can use them for different gestations, but essentially they are showing us the normal progression of jaundice in the first few days of life. So normally jaundice will increase over the first few days and then plateau out. And like I said, that's physiological. But if the jaundice levels reach these two lines, so the blue line is labelled phototherapy and the red line's labelled exchange transfusion, then these are the lines that we worry about. So this is, the babies are more jaundiced than we'd expect them to be, and maybe there's something else going on. So the phototherapy line is where we start blue light treatment, and the exchange transfusion line is where actually these babies have got really high levels of jaundice and they may need actually replacement of the blood and removing the blood with the high levels of bilirubin and antibodies in. Next slide, please. So why do we worry about jaundice? Why does it matter that these babies have very high levels of bilirubin? Well, we worry about it because it can cause permanent brain damage and even death to these babies. The jaundice that is caused by the breakdown of red blood cells is an unconjugated bilirubin, and it's water insoluble, it's bound to albumin, and it can cross the blood-brain barrier. And when it crosses the blood-brain barrier at high levels, it can deposit within the brain, and it's toxic to the brain. It causes permanent damage and leads to an encephalopathy and a disease process called kernicterus. So kernicterus essentially is the deposits of these bilirubin within the brain, and the babies will initially present just a bit sleepy, not feeding so well. They become lethargic, but then they can go on to have abnormal movements and seizures, and it leads to long-term brain damage. They'll have like a spastic kind of cerebral palsy, and if very high levels and they're not treated, can actually lead to death of the baby as well. Luckily, with monitoring in terms of antenatal screening, screening of the mums for antibodies, and also picking up babies who are jaundiced early on when they are born. So we monitor them very carefully, doing blood tests or kind of transcutaneous monitoring. Kernicterus is very rare. It only affects now kind of 1 in every 100,000 babies, but we do still see it. And actually, the babies we often see it in, the babies that might be missed, are babies with kind of Asian skin, which it's very difficult sometimes to pick up jaundice level visually. So we now advocate that all babies should be tested for jaundice, regardless of the visual kind of inspection, if they're kind of not feeding so well, or we're worried that maybe they might be showing signs of jaundice early on. Next slide, please. So like I said, we're monitoring. If we know that there's a mummy who's got an antibody screen which is positive, we'll ask the midwives to do cord gases. And from the cord gases, we can take bloods and look at the blood group, the direct Coombs test, and also the bilirubin and hemoglobin levels. If the cord bloods can't be taken, then we can do it from the infant after they're born within the first couple of hours. And again, we look for the same tests, and we're looking for any evidence of kind of hemolysis and any progression to hemolytic disease of the newborn. Next slide, please. So the direct Coombs or direct antiglobulin test, which I've been describing, is essentially a test to look for antibodies breaking down the red blood cells within the baby's blood. So what they do is they take the baby's red blood cells, and you can see on the left-hand side, the red blood cells have got the little blue antigens on it, and then these little green Y-shaped antibodies attached. So they wash the cells, and then they add a reagent in. And the reagent is this little orange kind of circular shape, and you can see it's got little projections coming out of it. And these reagents will attach to an antigen antibody complex on the red blood cell. So if they detect an antigen antibody complex on the red blood cell, they'll attach to the red blood cell. And you can see, because they've got lots of little projections, they can attach to a number of red cells at a time, and they cause the cells to agglutinate, kind of stick together. So if we see, or if the lab sees that agglutination or the sticking together of the red blood cells, then that's a positive direct antibody test. So we know that there's evidence of antibodies breaking down that baby's red blood cells. Next slide, please. And the DAT test can be reported in a spectrum, so from kind of weakly positive 1+ to strongly positive 4+. And this helps us to decide what's going on with that baby in the context of their clinical picture. We know if it's reported as 4+, which is strongly positive, then 100% of these babies will require phototherapy, and there is some kind of hemolytic process going on, whether it'll be Rhesus incompatibility or another incompatibility. But we know if they're 1+, so just weakly positive, it may be that they just require a bit of phototherapy. So 23% of these babies require phototherapy. So, you know, there's a high proportion, three-quarters of them don't require phototherapy. Sometimes from giving prophylactic anti-D, that can cause a false positive. So 15% of the weakly positive kind of 1+ DATs can be just because mums have had anti-D. But we also know that with ABO incompatibility, like I was saying, it's a milder form of hemolytic disease of the newborn, but 94% of babies with ABO incompatibility will be weakly positive. So it's all about taking it in context with the clinical picture, mum's blood group, in terms of interpreting the DAT test. Next slide, please. So as well as incompatibilities, there's also other reasons why red blood cells will break down more quickly. So you might have red blood cell membrane defects, enzyme defects, or hemoglobinopathies like thalassemias. So it's also important to look for these when we do our blood films. Next slide, please. So we've thought about kind of what causes it and how we diagnose it. So now I'm going to talk a little bit about treatments of hemolytic disease of the newborn. So I've alluded to some of them already, but we're going to talk about phototherapy, exchange transfusions, and then IV immunoglobulins. Next slide, please. So phototherapy, this is our first line treatment for jaundice. And if you've had babies or you know people with babies, quite a lot of babies do require a small amount of phototherapy for jaundice. And essentially what this does is it's the blue light, so the spectrum of light between 450 and 460 nanometers of light. And this blue light spectrum will break down the water-insoluble bilirubins, that bilirubin that can be dangerous at high levels that can deposit in the brain, into water-soluble bilirubin, which can be excreted in the urine. And you can see from the pictures, we have to protect the baby's eyes when we do this with little goggles. They can either be on a billy bed, which is a kind of mattress which has got the light underneath, or they can have an overhead light. And sometimes if babies have got high levels of bilirubin, we might want to use the underneath billy bed and lights on top so we can get the maximum surface of the baby's skin exposed to the light. And phototherapy, you know, is very effective. Some people say, you know, can we just put the babies in the sun? And, you know, that's something that people talk about for mild jaundice. And there is a small proportion of sunlight that has this wavelength within it that converts the water-insoluble bilirubin to the water-soluble bilirubin. But for more severe jaundice, it's not effective enough, so we need to use the medical phototherapy. Next slide, please. This is exchange transfusion. So this is, if you remember that graph, that top line, that line where actually the bilirubin level is at quite a worrying level, and we need to get it down fairly quickly before to prevent brain damage. So for this procedure, this should be done in a tertiary neonatal unit. So these are the babies that we might have to move to Cambridge in order to do it. We have to put central lines in, and what we do is remove small aliquots of the baby's blood and then replace it with whole donor blood. And it has to be very specific blood requested from blood bank. There are risks associated with the procedure in that because we're removing blood and putting in blood, we get shifts in volume. So the babies can have some cardiovascular respiratory instability. They can get some electrolyte imbalance. And it has been associated with some ischemic changes in the gut and also mortality. So it's not without its risks. But sometimes babies who have severe forms of hemolytic disease of the newborn do need to have an exchange transfusion. And lastly, the IV immunoglobulin is another method of treating hemolytic disease of the newborn. And we normally use it as a holding measure. So while we prepare for an exchange transfusion, getting the lines in, ordering the blood from blood bank, we can give the babies IV immunoglobulins. And essentially what the IV immunoglobulins do is they attach to the antigens on the baby's red blood cells to prevent the maternal antibodies attaching them and then causing the red cells to break down. So they kind of are mopping up those maternal antibodies. Next slide, please. So that was just a quick whistle-stop tour of hemolytic disease of the newborn. We've talked a bit about the history of it, when it was first described, the pathophysiology, thinking about Rhesus incompatibility being the most severe form, but actually we see it less often now. And then the ABO incompatibility, more commonly seen but less severe. We've talked about maternal IgG antibodies crossing the placenta, and actually that it's important in terms of baby's immunity but actually these are the problems in hemolytic disease of the newborn in terms of breaking down the baby's red blood cells. We've talked about diagnosis at the different time points, antenatally, postnatally, and then the laboratory tests we can use. We've talked about jaundice being pathological in the first 24 hours and how we need to look for causes of that. And one of the causes is hemolytic disease of the newborn. And then I've just touched a little bit on our treatments that we use. So phototherapy being the first line, exchange transfusions for the more severe cases, and then the IV immunoglobulins. Next slide. So I'd be happy to take any questions. Thank you very much.